Have you ever looked through patient files without consent to find interesting cases for teaching junior staff? How about in preparing for an exam, looking up a relevant case of a patient you didn't provide care for? Or wonder what happened to a patient that you saw once to find out what happened to them once they were admitted to hospital? These scenarios are incredibly common, but is it lawful? Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. And today we're discussing a situation that occurs probably on a daily basis, but no one really thinks about it until the HR department question you and raises the possibility of serious misconduct. And we've had recent calls about this very issue, and we'll discuss if these scenarios breach privacy. So whether you're in primary or secondary care, it is common practice to look for files of interesting cases for educational purposes, and it might be when teaching junior colleagues or for your own learning. Our public hospitals are teaching hospitals, and this is carried out every day. Registrar prepare for exams, urgent care doctors want to know what happened to the patient they've sent off urgently to hospital, and mostly we don't think about it. But is it okay, or is it a breach? To discuss this interesting topic, I have with me Adam Holloway, who's a partner at our panel law firm Watt & Carney. Welcome, Adam.
Hi, Sam.
We have with us Dr. Tim Cookson, who's a consultant to MPS, been with us and around the traps for a very long time. Nice to have you, Tim.
Hi, Sam.
And Lucy Gibbett, who is another colleague in GP, who is here to discuss this as well. Thanks for joining us, Lucy.
Thanks, Sam.
And my name's Dr. Sam King, and I work with MPS as well, and hopefully we'll have an interesting discussion, even if a little controversial at times. So let's start with the Health Information Privacy Code, or the HIPC. Tim, would you mind explaining which of the 13 rules applies to this situation?
I'll give it a go, Sam. So, health information, so the patient notes, scans, any results, all that is all health information. So Rule 10 limits the use of health information, so how all that stuff can actually be used. And under Rule 10, it says that the health agency, so for example, in this case, that would be the DHB or the hospital, that holds the health information that was obtained in connection with one purpose may not use the information for any other purpose. So the information's gathered in order to treat the patient and to be able to get them out of the hospital and all well again. That information, so all of the notes, in theory, cannot be used for any other purpose. So on the face of it, the registrar who then goes and looks for a case because they've been told that this was interesting and some interesting stuff they can learn from it. In theory, just based on that, that ought not to happen. However, there are lots of exceptions. So if the agency, or maybe the registrar, believes on reasonable grounds that the use of that health information for the different purpose is actually authorised, either by the individual concerned. And so, for example, if there was a specific consent that said, I'm allowing my information to be used for teaching purposes, then that's a teaching purpose, and I think that would fall under that. Or a representative of the individual gives the same consent, or that the purpose for which the information is to be used is directly related to the purpose and connection with which the information was obtained. It's a little bit of a stretch, that one, I think, to apply to this scenario. But there are other exceptions as well. So if the information is going to be used in a form in which the individual concerned is not identified, it's okay. Or if it's to be used for research purposes, for which may require ethics committee approval, depending on the type of research, and it's not going to be published in a form where the individual could be identified. So that's the main bits on the use of health information. Anyone want to make any comments at this point?
Yeah, it's a complex set of rules and exceptions, and it isn't a part of the Health Information Privacy Code that seems to speak directly and clearly to the key issue here, which is that, as I see it anyway, public hospitals are teaching environments. They are places where doctors learn through an apprenticeship model in some respects, and no matter what level they're at, they're always learning. There are always conversations being had about interesting cases. There are always consultants saying to an SHO who's thinking of getting on a registrar program, "Hey, look, this is a fascinating case we had over the weekend. I think you'll learn a lot from it. Perhaps go and have a look through the file." That sort of conversation is I imagine, happening all the time. And I don't think in New Zealand that we have a crystal clear set of rules about when it's okay and when it's not. I think we can certainly describe some examples where it's definitely okay, and perhaps we can come to that. But then there's another class where it's unclear and perhaps something that we need to keep working on as an overall system to get better guidance on.
Yeah, I wondered about that thing used in a form in which the individual is not identified, because that's that whole thing about use. And surely to use a thing, you've got to find it first. And the consultant who's looking for cases to teach on, when they actually use it, i.e. when they download it and share it with the students, they will have de-identified it. So the individual concerned will not be identified. So even if they actually looked it up in a file where the patient was identifiable, does that count as would that be all right to say, but I used it in an unidentified form?
Yeah, I think there's two answers there. I think for doctors, whether they're consultants or juniors who were part of the team involved in caring for that patient, it's pretty straightforward. They've already had a clinical relationship with that patient. You can then go, I think, and access the notes with a view to seeing whether they can be used for learning or teaching. You decide that there is an interesting image that you want to share more widely. You can take it, you can de-identify it, and then you can use it for that teaching purpose. I think that's fine. If it's a consultant who's been given the departmental task of teaching a session on some condition or presentation, and they don't have any of their own cases that come to mind, and they're going and looking at colleagues' cases, so cases where they had no clinical contact with or involvement in the care of the patient, I think that's where it starts to get tricky because of the lack of clarity. I think there are some really sound legal arguments that could be made about why that should be okay, that we can interpret the Health Information Privacy Code in a way that says that that's okay and that it would be consistent with the reality of how hospitals work. But it's not crystal clear. I think you have to pause if you are going into the notes of a hospital to look for cases that aren't yours or you weren't involved in. And I think the other problem that may be encountered, not only with privacy law, is that you might run up against the hospital's own internal policies and rules. It's not uncommon if you're going into the notes to have to tick a box that says, I've got a clinical reason or I was involved in the care of this patient. And you can't tick that box if you're just going hunting for interesting images.
So that some of what you mentioned leads on to another rule, which is to do with disclosure of health information. So you could argue that the information that's been gathered is to be used for teaching, or say, for example, a registrar might be giving a paper somewhere on interesting cases to other registrars not in the same organisation. So there are also limits on the disclosure of health information, which is Rule 11. And the health agency must not disclose the information unless they believe on reasonable grounds, and it might be it's reasonable to disclose it to the individual concerned, but that's not what we're talking about at the moment. But compliance with this rule that it may not be disclosed is not necessary if the health agency believes on reasonable grounds that it's not either desirable or not practicable to obtain authorization from the individual concerned, and that the information is to be used in a form in which the individual concerned is not identified. So that, for example, could apply to someone who had been discharged 4 weeks earlier, and it's not practical to try and get in contact with them to get specific consent to access their information and to use that information for the purpose of giving a talk, for example. But if you're not going to identify the patient and they can't be identified from your description, then there seems to be a reason under the exceptions that allows for that. And again, you can also, if it's for research purposes, and again, if the individual can't be identified. So in terms of release of health information, disclosure, there are some exceptions that could apply as well.
Yes. So you've got the use. Can I, as a staff member of a hospital, go and look at clinical information for my own learning purposes or for teaching within the hospital environment? And then you've got disclosure. My view is that if you are keeping the information within the hospital, then that's not an instance of disclosure, so Rule 11 never becomes engaged. You don't need to concern yourself with the limits on disclosure because fundamentally the information is not being disclosed outside of the agency. If you were going to, as a consultant, go and teach students at a university or take information to a group beyond the hospital, it raises interesting questions around what's an agency, an environment where we've got Health New Zealand really is the one super agency. But I think if you're going beyond the hospital, you have to then think about the rules around disclosure. And while there is that exception about being used in an anonymized form, it still asks you to form a view before you rely on that about whether it's either not desirable or practicable to obtain authorization. And I think if you were taking a photograph, for example, of a patient that had been anonymized by having distinguishing features covered by a black box, but wanting to use that for a poster or teaching at a university, you'd be wise, I think, to ask for consent, because there's not, if the patient's contactable, then I don't think you can say that it's not practicable to ask them, and perhaps you then should be asking for that consent rather than just saying, well, it's anonymized, it doesn't matter.
And the anonymised bit has also got some fishhooks in it as well, hasn't it? Because there might be a case where the specifics of that case are so unique that if someone else happened to know about it and then they hear about that particular case in a lecture, and they would say, oh yes, that's Joe Bloggs. I remember that was the case, in which case it's no longer not identifiable.
I have to say I had a case where there was images that were used unidentified on a website, but unfortunately the file name of the images included identifiable features, and so that if you searched those patients' names on the internet, those images came up because it was in the file name, even though it wasn't on the website, which was obviously a problem. So yeah, de-identifying isn't quite as easy as you think it might be sometimes.
Yeah, I mean, I guess we come back to the point that it is complex. These rules are pretty hard for doctors who it's not their job to be intimately familiar with the minutiae of privacy law, and it would be good to have some really straightforward guidance about how to use or how it's permissible to use information in teaching. And I had a bit of a look before we all met today, and the General Medical Council in the UK have in my view, a much clearer statement about this, which I hadn't taken the time to look, but I assume it's consistent with the UK's rules around privacy for the GMC to have taken this position. But they have 3 paragraphs in their guidance: teaching and training of medical students, doctors in training, and other healthcare students and trainees. And say most patients understand and accept that education and training of medical students, doctors in training, and other healthcare students and trainees relies on them having access to information about patients. If you're part of the team providing or supporting a patient's direct care, you can have access to their personal information, unless the patient specifically objects. So you don't have to ask for permission, but if a patient says no, you'll have to have a system for recording that objection. If you're not providing or supporting the patient's care, then information should be anonymized. But even then, it acknowledges that may not always be achievable, for example, on ward rounds. So you're going on a ward round, first time as a junior doctor you're seeing this patient, you're going to be told health information about them for the purposes of learning, and this recognises that that's fine. And then in some cases it may be necessary to disclose personal information, or it might not be practical to anonymise it or ask for a patient's consent, and it goes on to talk about that. So it is an engagement with the reality of a teaching environment, and it would be nice, I think, in this jurisdiction if we could have something similar. And I say that not only because clarity is a great thing, but we do occasionally have cases that are referred to us where a doctor has been looking at clinical information for learning purposes, preparing for an exam or what have you. It just so happens that they've, clicked through some file that later gets audited. Potentially the file they've clicked through is someone notable, or there's been some other privacy breach that's occurred because of the actions of a different individual that then sparks an audit, and then they're called in for an employment meeting to say, we've got evidence here that you looked at this person's clinical file, you weren't involved in their care, which is a very frightening thing to occur, and difficult, I think, for that doctor to then have a highly legalistic argument about why it ought to be permissible to use clinical information in a hospital for the purposes of learning, where while it's not anonymised, the identity of the individual was irrelevant to the viewing. They weren't interested in who they were, they just wanted to see a CT head.
Sometimes that's quite hard to prove when it is a high-profile case that a lot of other people want to look at. But the practical side of this, though, if it was that you needed patient consent, and we can talk a little bit about what that consent ought to involve, if it's not practical to do so, and a lot of times I don't think it is, can you imagine the teaching around every hospital in New Zealand would probably grind to a halt, because I expect this is incredibly common practice. And so it would be really good to get further clarity on it, I agree. So if we think about the consent, I actually tried to find out what our hospitals do in terms of consent, and I was able to only glean a little bit, and I this is not definitive. This is not to say that this is Te Whatu Ora's policy or anything like that, but this is what I was able to gather, that most hospitals, or there are some hospitals who do have an explicit statement regarding consent for having medical and clinical students and other allied health students to have involvement in the clinical care or observing the clinical care of a patient. And so the consent might involve things like the assistance for students to be involved with specific procedures, like putting in drips or whatever that happens to be, so they consent to those sorts of things. And there's also a separate consent for students to observe or perform sensitive examinations. But I couldn't find anywhere in talking to hospital clinicians that there's specific consent requested for looking at patient files.
For people who are not involved in the
That's
clinical
right,
care of the
involved,
patient.
and for
if you're
teaching purposes.
with the team on the ward round,
Of course, that's slightly different.
Whereas actually the issue is if you're just looking at notes.
That's right. If you're looking at notes and have no part in the clinical care, there was nothing specific that I could glean from the clinicians I spoke to anyway to suggest that actually happens. So Adam, what would be sufficient consent, do you think, for this kind of scenario where for teaching purposes we're going to look through patient files? Is it okay for people just to sign something when they're admitted? Is that sufficient, do you think?
If we're talking about use rather than disclosure, I think there are two ways of trying to legitimise well-intentioned, above-board access to clinical records for learning and teaching purposes. One is to say that the Health Information Privacy Code permits this anyway, and you don't need consent. One of the exceptions is that the information is to be used for research purposes and will not be published in a form that could reasonably be expected to identify the individual concerned. There haven't been any cases to explain what research purposes means or how widely that should be drawn, but I think there is an argument to be made that must have been intended to capture the sort of apprenticeship learning that takes place in the real world. So that would be one way of saying, look, I think that the rules we have should recognise the reality of it being okay for people to access clinical records, even of people they weren't involved in the care of for learning purposes. The other would be to try and rely on it being okay to use information where there's been some permission. And so I think then you would have to have a very comprehensive and systematized way when people are being admitted to hospital or presenting to ED to make it clear to them that their clinical records may be used for learning and teaching purposes, and they can have the potential to opt out. I think the issue that raises for me is just a practical one of how does then the system of hospital records capture the people who opt out? How do you then navigate through records knowing who's put a tick in that box and who hasn't? The state of Te Whatu Ora IT, I'm guessing, is probably not such that that's going to be a workable solution. So it would certainly be better to have, for example, the Privacy Commissioner issue an advisory opinion that says, look, it's actually okay. This is research purposes. It counts. People should be able to relate the details of a case to another colleague so they can learn from it, rather than rely on patients needing to be told very explicitly at some point in time near the beginning of their health journey that this is what's going to happen and be given the opportunity to opt out. I can see real pitfalls with that.
I mean, even though patients give consent for students to be involved in their care or to observe procedures, etc., explicit consent is usually obtained at the time Well, you would hope that it is anyway. So that if a student's going to be in theatre with the patient would be specifically advised of that and asked for consent at the time, even though they might have signed it already at the time of admission. And so you've got layered consent, if you like.
Mm.
But in this situation, I think it's probably much more difficult. It's just not that practical to obtain that specific consent at the time. Yeah, so interesting questions, and I think maybe it's worth us perhaps trying to speak to the Privacy Commissioner about that to get some form of guidance.
Yeah, and I think in the meantime, if people are listening to this podcast and worried or thinking about, okay, well, what have I done or what do I do as part of my ongoing learning or my, working towards some big exams, rather than trying to master the Health Information Privacy Code, which, as we've discussed, arguably doesn't give a very clear answer on this. Things to think about are your own internal hospital policies and rules, because even if we can make an argument that this should be permitted under the code, there may be an internal set of rules that you last looked at when you first joined the organisation that say this is not okay, that you can only access clinical records if you are involved in the care of a patient. And if that's the position, then those are rules you need to reacquaint yourself with, and I would then be thinking about contacting the hospital's internal lawyers, or perhaps going through the union or getting the registrars together to say, hey, this is what we want to be able to do. This is what we understand your internal rules say. Can you just help us out? We need to be able to, for example, go through CT heads that have been ordered from the ET department to have a good understanding of the range of images we might be confronted with in our upcoming exam. Tell us what we can or can't do. So don't try and shoulder the burden of getting to the right legal answer yourself, because it may not be a clear answer, but get hospital management involved if you can, or perhaps your union, to advocate for what's a really critical part of your role. You're being employed not only to do the work, but to continue to train.
That's really good advice. Yeah, that Te Whatu Ora would be best to provide some kind of policy statement so that all their employees can feel secure, that they can follow it. Lucy, is there anything in the Health and Disability Commissioner's Code of Consumer Rights that relates to this?
Your right 6, which is the right to be fully informed, is probably relevant. That says that every consumer has the right to the information that a reasonable consumer in that consumer's circumstances would expect to receive. And that includes, one of the parts below, is that they should include notification of any proposed participation in teaching or research, including whether that research requires or has received ethical approval, and also any other information required by legal, professional, ethical, or other relevant standards. So, reading right 6, it seems that a reasonable consumer may expect to receive notification about proposed participation in teaching or research. Interesting that they use the word notification rather than consent. It looks like that a reasonable consumer should be told, you're in a teaching hospital. Part of being in a teaching hospital is that we have students. Those students may have access to your health information, and notify them of that. So it's interesting that it doesn't say consent there.
But again, it sounds like it's an opt-off system. And as Adam was saying earlier, from a practical perspective, where do they store that information? How is that to be accessed in a reliable way? So yeah, that's very interesting. So finally, let's now think about a couple of primary care scenarios. I think particularly in urgent care, where they're treating patients who are not enrolled under the clinicians, it's not uncommon for the clinicians to look up patient files on TestSafe or Health One to find out the outcome of those particular patients for their own learning, and interest. Is that okay? Tim, what do you think?
Well, certainly if they've asked the patient at the time, look, I'd be really interested to know what happened. Do you mind if I look it up? And the patient says yes, then that's great. I'm not sure how that ought to be recorded, because just a verbal yes, if there's a dispute about it later, may not be sufficient. So I think with consent, absolutely clear, there's no problem with that. Without consent, I think it's a real grey area, because that's going on to information that you were not privy to at the time. And there may be developments which the patient wouldn't want you to know. So you presented with your sore toe, but it turns out that it was due to some incredibly rare illness that had sort of connections to your sexual activities 20 years ago. You may not want the original doctor to know that. I don't think that's acceptable.
Yeah, you don't have an ongoing duty of care to that patient. There's no, your therapeutic relationship is ended. So I would have thought, in fact, it was...
I'm going to argue with that, Sam.
Okay.
In that, I kind of think it depends. So if you're a primary care doctor and you've referred a patient into hospital for whatever because you're concerned about something, and that's a referral, and you're allowed to get a letter back from the referring doctor. If we refer somebody for, I think this person may have renal colic, that doctor that you've referred to is allowed to write back to you.
Well, we know that in urgent care that doesn't happen. It goes to the GP, right? The enrolled GP. But I hear what you're saying.
I think the hospital clinician is entitled to write back to the referring doctor, aren't they?
I'd say yes, because you're still, in that scenario, you're still the patient's GP. You're still providing care to them, and this information still is relevant or potentially relevant to that ongoing.
What if you're the urgent care doctor? Yes. What if you're the urgent care doctor and you've referred someone to ED? Do you have and one of the common scenarios of this is skin cancer doctors, where they're not actually the enrolled GP, but they're seeing the patients recurrently for skin issues. If they then refer them up to the hospital for further treatment or surgery, the skin cancer doctor who does that referral, do they have a right to get a letter back about what was found? I think they do.
Yeah, I don't see a big issue with that. I think it more commonly becomes a problem where someone has not been referred but transferred. Or so, there's been a
so urgent care to ED rather than skin care.
Or from a consultant where something's gone not well and they've said, look, I think you should go on to my colleague for continued care. Or I don't know, there's been an anaesthetic emergency and, the anaesthetist conduct is at issue, but the anaesthetist is really interested in how they're now doing in their recovery, 4 months down the track. I think those are situations where I would pause, because it's not a referral. Yeah, it's just, this is no longer my patient, but I'm interested in how they are doing because something didn't go well when I was caring for them. I think in those situations you have to be extremely careful.
When you say they weren't referred, the reality is that urgent care do refer to the hospital. I guess the question that in my mind is, would the patient expect that somebody who's not your enrolled GP will go look in your file for future care that you receive? And if you're going to look in someone's file, often you're not just seeing the results of that particular episode of care, but you're seeing, you've got the list of all of their results and clinic letters and all that kind of thing. And I'd be a little cautious.
And in this specific situation, it may be that the plan of action from the urgent care is to go back to the GP for further investigations, in which case the urgent care hasn't referred on to anybody. They've just said, go back to your usual GP. I'll do these initial investigations, but you'll need more. And it's the GP who's then handling the ongoing investigation. And I don't think in that situation the urgent care doctor has any right to go and look at the information.
Unless they asked in the first place, which is what you said, when you have an interesting case that you're referring to ED, you probably should say, oh, look, I'm really interested to see how this turns out. Would you be happy with me to look in your notes in a week's time to see what's happened?
And I mean, as we know, when I log into TestSafe, you have to break the seal every time. And TestSafe, every access is, well, they do audits, essentially. So it's possible for someone to say, well, you've looked this up and they're not your enrolled patient. What are you doing in there?
Of course, there are different systems around the country.
Yeah, I don't know what Health One do, but up north, or every time you have to break the seal now.
I think in the South Island, pretty much all doctors have got access to all health information, haven't they? There's a
but
they get all, there's a system for them.
I don't know if they have to break a seal as well.
Yeah, if they look at a patient that isn't their enrolled patient, I think they get a notification of why did you do this.
So if we just take that a little bit tangentially, Lucy, I know that a number of our members like to look up what's happened to a patient subsequently, even though the patient's transferred care when they've received a complaint. Is that okay?
That's such a common issue. So we're talking about when it's a non-enrolled patient. So you've seen the patient either in an after-as or for a colleague. So they're not your patient. They've made a complaint about the care they received, and that doctor often really wants to know what happened because, to explain the complaint and for other reasons. But I think we're reasonably clear in that situation that the doctor doesn't have a right to look at the notes. If they're unenrolled, they're not involved in their care anymore. They're allowed to look at the notes that they made, because those are their notes. So they are allowed access to the notes that they made. And they probably also have access to what they had access for at the time when they saw the patient. So if when they saw the patient there were letters in the file or results in the file, so that the doctors saw those when they saw the patient, they probably have a right to still see them, because you can't breach privacy for something they've already seen. But I don't think that they do have a right to see what's happened and to look to the future. And we are often talking to members about that, about the fact that you really can't go looking to see what the outcome was.
I've certainly had a case where the patient made a second complaint because it was very obvious from the doctor's response that they'd looked forward in the notes. Yeah. So we've had an interesting discussion this morning. So Adam, would you mind just maybe give us some take-home messages?
Yeah, I'll start before I move on to that, just briefly touching on what you've just discussed, because dealing with complaints is obviously something we do. If it's been alleged that, for example, you didn't do the right investigation and something bad happened, and the reason you want to look at notes that occurred after your involvement is to test the veracity of that allegation, then that's something MPS and us, if it involves a lawyer, can help with. Because while we would advise against going into whatever systems you have available to see what happened yourself, because that can be audited and you can get into trouble, there is nothing wrong with MPS or a lawyer or you with assistance writing to the HDC to say, look, I need to know this information to be able to respond properly to this complaint. And the HDC will doubtless or probably have the notes you're interested in, and they are permitted then to share those with you or to negotiate with the patient so that you aren't disadvantaged in terms of providing a response or testing the veracity of what's been said about the care you provided. So there are ways around that. But anyway, you asked for some take-home messages.
Sorry, Adam, just picking up on that point.
And he's opened a can.
Just on that point, the HDC aren't necessarily forthcoming with providing all the information that we think is reasonable for our members to have access to. And I wonder whether such a request would be successful through the HDC, to be honest.
It probably depends on the case and the reasons you're putting forward for needing to see that information. how we would generally do it is write a letter saying, look, we're particularly interested in this, and this is why it's fair that we see it, but we are we're happy to make this request under the OIA, under the Official Information Act, and just put the HTC to the task of coming up with a reason why they're going to withhold that from us if they choose to, and then we can have that battle with them. You're absolutely right, Sam. It's not always going to be straightforward, but God loves a trier, and if you've asked and not been given it, and then you get an adverse outcome down the line, a breach finding, you have a reason then to argue why that's unfair. And ought not to be sustained, because you're put in a position of, still not knowing potentially pertinent information. Time for take-home messages. This is a difficult area, I think, is the first take-home message. And, apologies for the lawyers not being able to give you a clear answer. I think the first thing I'd say is consent is valuable, and that the HDC's whole reason for coming into being was issues around patient consent and patients being involved in research that they hadn't consented to. They're always going to put that at the heart of their perspective when they're looking at things. And the HDC's code does say that patients, you have to seek their consent for their involvement in research and in teaching. So there's a tension between the rules we have on privacy, the rules we have from the HDC, which one takes prominence, what are the privacy rules even saying. But if you are in a position where you're able to get consent to have that conversation, start there, because it is a cure for the uncertainty. To be able to say to someone, hey, look, I'm sending you off to the hospital because I think this might be a break, it might need x-rayed, but I'd be really interested to know, are you happy for me to follow that up, just so that I know how this turned out for you? Perhaps an easy and simple conversation to have. You're a consultant with someone who's, a really fascinating case. Hey, look, this is a teaching hospital. Tomorrow I'm going to be talking to a team of registrars. Do you mind if I talk about your case in an anonymized way? Because, this is such a rare presentation. I've never seen it quite like this. Quick conversation to have, potentially. And if you are in a position to do that, my first take home would be do that, because then you've done it, and you're not then relying on lawyers and interpretations of rules about whether or not what you've done is okay. The second take home I'd say is that if you are planning on looking in the notes of patients who you haven't been involved with, you weren't part of the team providing care to them, then make sure you're familiar with your policies of your workplace, and that you're not going to be breaching those by going in and looking at those records. If you're not sure, or if you think you will be breaching those rules, then I would get other people involved in tackling that problem, so that you are able to have the sort of access or ability to use information that you need to do a good job of in your training and taking on the challenge of your examinations. Those are probably the two main things I'd say, Sam.
Thanks, Adam. That's really helpful. Well, I hope we've clarified the topic a little bit, even though we haven't been able to give definitive yes, no, this is okay or not. Thank you for listening to this podcast. I hope it's been helpful. Our next podcast will be talking about protected quality assurance activities, and we'll hope you will tune in for that. We look forward to catching up with you in this next podcast. If you like the medical protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org. Thank you, Tim and Lucy, and thank you, Adam.
Thanks, Sam.
Cheers.